Okay, let's unpack this. We are diving deep into what I think of as the ultimate orthopedic internal audit, ACL graft selection.
Hmm.
Given the sheer volume of these procedures, we're talking an estimated 300,000 ACL reconstructions performed annually. The choice of tissue dictates the long-term success of, tens of thousands of athletic careers every single year.
It's a mandatory audit, especially now. What's fascinating and frankly a little concerning is the continued prevalence of allograft usage,
Right.
especially despite the known risk profile in certain demographics. Registry data shows that globally, roughly 30% of primary ACL recons still rely on allograft tissue.
30%.
And in some larger community settings, particularly those focused on efficiency, that number climbs as high as 41%.
That 41% figure is staggering when you hold it against the failure rate data we're about to review.
It is.
It points directly to the central conflict here, the clinical temptation of allograft. On one side, you have the desire to eliminate donor site morbidity, no pain from where you harvested the tissue, which is the massive operational advantage of allograft.
Exactly. But on the other, you are chasing that long-term mechanical stability and, that biological certainty, and that remains firmly in the autograft's domain.
So that's our mission.
Our mission today is to perform a rigorous, cold-eyed assessment of the unique risks and disadvantages associated with using non-patient tissue.
Yeah.
Because when we counsel a young, high-demand athlete, we need to move past the general statements about risk and provide truly informed consent.
Rooted in hard data.
Rooted in hard, specific data about failure and re-revision rates.
Absolutely. So let's start with the incumbents, the autografts, or as we often refer to them in surgery, the gold standards that the allograft is trying to replace.
Let's do it.
We have to begin with the bone patellar tendon bone, or BPTB autograft. It's the historical benchmark the Graft Jones first described way back in 1963. Despite all the advancements we've made, it remains the gold standard for a reason, doesn't it?
It does. When it comes to mechanical properties and biological healing, BPTB is exceptional. It provides extremely high initial tensile strength, just very robust on day one.
And crucially,
It allows for fast bone-to-bone healing. This means the bone plug integrates directly into the tunnels, which is widely accepted as the strongest form of biologic fixation we can achieve in this surgery.
so if your priority is just maxing out stability,
If your priority is maxing out stability and rapid initial fixation, BPTB is the benchmark. Full stop.
But as with all gold standards, there's a hefty price. And for BPTB, that price is paid directly at the anterior knee donor site.
Right.
It feels like we trade long-term stability in the joint for almost guaranteed short to medium-term pain in the front of the knee.
That is the most common complaint we hear in post-op clinic. It's relentless. The donor site morbidity of a BPTB harvest can be categorized into static and dynamic disadvantages, and we need to be transparent about both.
Okay, so let's break that down. What are the static issues?
Statically, the obvious issues are the highly common anterior knee pain, particularly pain during kneeling, which can be debilitating for some patients.
Just functionally, day to day.
Yes. And then you can get patellar shortening, sometimes decreased range of motion, and in rare but serious cases, a patellar fracture or patellar chondrosis, actual damage to the cartilage behind the kneecap.
And the dynamic issues, those are what really affect high-demand performance, correct?
They absolutely compromise performance. The dynamic disadvantages include measurable decreased quadriceps strength and often significant lingering quadriceps inhibition.
It's like you've taken a piece out of the engine.
You've taken a central piece out of the transmission cable of the extensor mechanism. If you imagine the quad tendon system as a bicycle chain, we've removed a few key links.
That's a great analogy.
And this can also lead to altered patellar alignment over time, compounding the chronic pain issues. It's a trade-off that is almost non-negotiable for high-demand athletes whose entire livelihood depends on maximal quad power.
Now, moving to the hamstring graft, specifically the quadrupled semitendinosus and gracilis construct. Biomechanically, these constructs are fantastic.
They are.
They have been proven to show the highest tensile strength of all the autograft options immediately after harvest. If we're talking about pure force required to break the graft, the hamstrings often win.
It's why the hamstring autograft has become the most widely used graft worldwide. I mean, in the U.S., it's about 30% usage. But in places like Denmark, the usage rates are 68% up to 85%.
Wow.
It is the overwhelming dominant choice there. The morbidity is generally perceived as lower than BPTB because the pain is posterior thigh pain rather than that debilitating anterior knee pain and kneeling issues.
However, this shift to soft tissue introduces its own specialized weaknesses, in which specific athletic demographics does harvesting the hamstrings become detrimental.
The primary downside is the loss of strength in two key movements: knee flexion, especially past 90 degrees, and hip extension. For the general population, this is typically clinically insignificant. But for specific high-demand athletes, being sprinters, wrestlers, gymnasts, martial artists, or anyone who relies on powerful, acute flexion or extension moments, that strength deficit is real.
It's like taking the turbo boost out of their engine.
That's exactly it.
And there's that critical neuromechanical detail, the disruption of the reflexive protection, which is often the reason some surgeons avoid it in high-risk athletes. It's not just the strength loss, it's the loss of a built-in sensor.
Exactly. We're talking about the ACL hamstring reflex arc. The hamstring muscle complex naturally acts as protective shield for the ACL, contracting subconsciously during potentially high-stress valgus or rotational moments to tighten the joint.
It's an active stabilizer.
It's an active stabilizer. And by removing the semitendinosus and gracilis, you disrupt this arc, decreasing the reflexive protective effect the hamstrings would otherwise provide to the reconstructed ACL graft. You've lost a physiological safeguard that the native knee relied upon.
Plus, you are dependent on the intrinsic graft quality, which is the constant worry during harvest. You can't always control the preoperative quality. I recall figures showing that decreased graft size, a thinner tendon bundle, is strongly correlated with a higher risk of revision.
That's a key factor. Studies, like those from Magnuson, clearly show that hamstring graft size is a predictor of early revision risk. If you harvest a small, thin tendon, you start with a biomechanically compromised construct,
Which puts you in a tough spot intraoperatively.
It forces us to consider potentially needing allograft augmentation during the procedure if the autograft harvest is subpar, or opting for a BPTB if we suspect smaller tendons, which happens more often in smaller patients or female athletes.
Finally, let's bring up the quadriceps tendon autograft, which has become increasingly popular over the last 5 years or so. Where does this fit into our decision-making algorithm?
The quadriceps tendon graft, especially when harvested with a patellar bone plug, making it a QTB autograft, offers stability and overall functional outcomes that are pretty much equivalent to the BPTB autograft.
So it's a real contender.
It's gained favor because it is truly an excellent compromise graft.
What's the primary patient-reported advantage over BPTB?
It comes down to pain. While overall anterior knee pain is reported similarly to BPTB, the major finding in clinical studies is significantly less kneeling pain reported at the 2-year follow-up mark.
And why is that?
We're harvesting the plug from the superior pole of the patella, leaving the central patellar tendon, the crucial area for kneeling pressure, intact.
So you're avoiding the main pressure point.
Exactly. If you have a patient whose profession or hobbies demand frequent kneeling, think tile layers, electricians, or just parents who kneel to play with their kids, the quadriceps tendon graft may offer that crucial quality of life advantage by avoiding the central tendon harvest scar tissue.
Having established the inherent pain trade-offs of the autograft, let's explore the option that promises to eliminate that secondary pain source entirely: the allograft. Operationally, this is the ultimate buy versus build decision, and for the surgeon, the advantages are incredibly compelling.
They are. The overwhelming operational advantage is the elimination of donor site morbidity and pain. For the patient, this means the only source of pain is the procedure itself, not a secondary harvest site.
And for surgeon?
For the surgeon, this translates directly to decreased surgical time, which reduces or costs smaller incisions, and a frequently faster subjective recovery time. Patients just feel better sooner because they don't have that secondary pain source.
We also gain predictable graft sizes, which is huge for planning complex cases or revision cases where we need a specific diameter.
Oh, absolutely.
And literature suggests a lower incidence of arthropibrosis, that dreaded stiffness where the knee scars down, compared to the more invasive autograft harvests.
Yes, and the sheer variety of tissue available is a logistical asset. We can select from patellar tendon, hamstring, Achilles, tibialis anterior, quad tendon, or fascia lata. The tissue bank offers a menu of options, providing the surgeon maximum flexibility.
Okay.
But we must be absolutely clear with the patient. We are exchanging surgical convenience for a massive biological compromise.
The hidden costs are where the audit truly focuses, particularly for the young patient. The drawbacks are fundamental: biological vulnerability and compromised mechanics.
Right. On the biological front, even though the risk is highly minimized, we must counsel on the potential, however remote, for disease transmission and the possibility of an immunologic reaction.
But the real issue is...
But the most clinically relevant issue is the slower incorporation, that prolonged period where the graft is functionally dead tissue.
It's just a scaffold.
It's just a scaffold. The graft takes longer to remodel and revascularize, which directly impacts postoperative laxity and stability. Mechanically, this translates to inferior biomechanical strength compared to autografts, increased postoperative joint laxity, and a higher incidence of tunnel expansion over time.
That delayed biological incorporation is truly the Achilles heel of the allograft. It's like installing a new bridge, but the concrete takes 9 months longer to cure than you expected.
That's a perfect analogy.
That vulnerability sets the stage for the most critical outcome, which is the significantly increased failure rate in select patient populations, particularly young, high-demand individuals.
Precisely. We are demanding the same performance from tissue that is structurally and biologically inferior for a measurable period of time. This compromise in biology is why we have to be so meticulous about understanding the procurement and sterilization process.
Let's talk about the supply chain. The tissue bank industry is thankfully highly regulated now, but this is an area where the surgeon must be fully aware of how the tissue they are implanting has been handled.
The regulatory framework is robust, mandated by FDA Good Tissue Practice and American Association of Tissue Banks, or AATB, guidelines since the mid-2000s. The entire process hinges on eliminating high-risk donors and maintaining sterility.
And that process starts with incredibly strict screening.
It's a rigorous, multi-stage process. It involves a detailed review of the donor's social history, often including a physical examination for high-risk behavior markers like needle marks, and mandatory comprehensive serologic testing.
So you're testing for everything.
We test for HIV types 1 and 2, hepatitis B and C, HLV-I and 2, and syphilis. Crucially, AATB-affiliated banks mandate the destruction of any tissue that cultures positive for virulent bacterial pathogens like Clostridia or Group A Streptococcus.
It's a zero-tolerance policy.
It has to be a zero-tolerance policy to protect the recipient.
This section is critical because it directly addresses the kill the virus, kill the ligament problem. It's where the pursuit of sterility actively destroys the structural integrity of the very tissue we're implanting.
It is the ultimate paradox of tissue banking. High-level irradiation, generally defined as greater than 25 kcal or 1.8 meprad, is highly effective at reliably inactivating resistant pathogens like HIV and bacterial spores.
But
However, those same high levels severely compromise the biomechanical properties of the graft. The energy breaks down the crucial collagen cross-links we rely on for tensile strength.
And we don't have to rely on theory here. We have concrete data demonstrating this failure mechanism. I remember the prospective randomized studies by Sun and Rapp that really forced the hand of the orthopedic community on this practice.
That data is utterly sobering and completely changed our approach to allograft sterilization. In the Sun et al. Study comparing BPTB autograft, non-irradiated allograft, and irradiated allograft at 2.5 Merd, the results were unequivocal regarding stability.
What did they find?
Irradiated allografts showed a significantly inferior stability profile, with only 31.3% of patients achieving less than a 3 mm side-to-side difference on KT2000 testing.
And that's the device we use to objectively measure anterior knee laxity.
Exactly. So only a third of them had what we'd consider an objectively stable knee.
Compare that 31.3% success rate to the other groups.
It was stark. Autografts achieved that benchmark stability 87.8% of the time, and non-irradiated allografts achieved it 85.3% of the time. The irradiation literally cut the probability of objective stability by nearly 2/3.
And the failure rate was equally dramatic.
The failure rate was catastrophic. Irradiated allografts failed in 34.4% of patients.
A third of them failed.
A third of them. Compare that to just 6.1% for the autograft group and 8.8% for the non-irradiated allograft group. The Rapé study found a similar failure rate of 33% in irradiated Achilles allografts at only 6 months. That data simply mandates cessation of high-dose irradiated tissue use.
So, high-dose irradiation sacrifices structural integrity for sterility, leading to clinically unacceptable failure rates. The analogy I use for my students is you're trying to sterilize a rope by setting it on fire. It's sterile, but now it can't hold any weight.
Precisely. The takeaway is that if we consider using an allograft, the processing technique is paramount, and high-dose irradiation is a hard contraindication for a primary reconstruction.
It's off the table.
Completely off the table. The literature comparing autograft to non-irradiated, non-chemically treated allograft tissue showed no statistical difference in key short-term outcomes in older patient cohorts. Processing is the key variable here.
we must address the anxiety surrounding disease transmission, even if the risk is statistically low. The risk of HIV transmission is commonly quoted at around 1 in 1.6 million, which is extremely rare.
Very rare.
But hepatitis B and C risks are consistently shown to be slightly higher, though still minimal compared to other daily risks.
Yes, and while viral transmission is a theoretical concern that has largely been eliminated by screening, we cannot ignore the bacterial concerns, especially spore-forming anaerobes like Clostridium sopp.
Why are they such a problem?
Because spores are highly resistant to standard sterilization methods, they pose a specific threat. The CDC reported outbreaks associated with allograft tissue in the early 2000s. In 2002, they identified 26 cases of allograft-associated bacterial infections, half of which were Clostridium infections, and one resulted in death.
And they followed up on that.
A follow-up 2004 CDC study reported 70 cases.
That underscores why the AATB mandates the destruction of tissue positive for Clostridium. But what about postoperative infection risk in general, comparing the different graft types? That data is surprisingly granular.
It is, and it's important to acknowledge that the risk is multifactorial. The Moon database reviewed risk factors and found that compared to BPTB autograft, using hamstring autograft, any allograft, or combined grafts, were all associated with an increased risk of infection.
So BPTB autograft was the lowest risk?
In that study.
Yeah.
Conversely, the Kaiser registry provided slightly different nuances, finding that hamstring autografts specifically had a higher incidence of infection compared to both BPTB autograft and allograft.
Interesting. So it's not a perfectly clear picture.
Not perfectly clear, but the overall infection rate remains very low, around 0.48%. But these findings highlight subtle variations in risk based on the tissue harvest or type, and we must include this in our consent process.
When we talk about graft success, we are ultimately talking about biology. The graft has to transform from a piece of dead or vascular tissue into a living, functional ligament surrogate, a process we call ligamentization.
Exactly.
Let's start with soft tissue healing, which is required for hamstring and all soft tissue allografts.
The native ACL is a biological marvel. It inserts directly into bone through 4 spheralized zones, a gradated structure that efficiently manages stress. In reconstruction, we're not that sophisticated. We rely on indirect insertion, using Sharpie fibers to anchor the tendon within the bony tunnel.
So it's a less robust healing process from the start.
Inherently, yes. It's slower and less robust than bone healing.
Let's use the timeline from the classic rabbit models to give the listener a clinical perspective on this fragility, because this is where the patient's impatience collides with biological reality.
The timing is crucial to manage patient expectations. We tell them, think of the ligamentization process like a major construction project. At 2 weeks, necrosis of the graft begins. That's demo day.
So it gets weaker before it gets stronger.
Much weaker. By 4 weeks, the graft is entirely acellular, relying entirely on the old collagen scaffold for structural integrity. Cellular repopulation and vascular proliferation only start becoming appreciable around 12 weeks. That's when the structural steel arrives.
And it's still not ready then.
Not even close. The graft achieves cellularity similar to a native ligament around 6 months, and true maturity, histologically similar to a native ACL, takes approximately 9 months.
9 months just for the tissue to look like a mature ligament, and that is the autograft timeline, which benefits from being made of live tissue.
Right.
What's the specific biological compromise when we introduce an allograft?
The fundamental problem is that allograft incorporation is demonstrably slower. It's like using prefabricated frozen materials for the construction project.
So the timeline gets pushed back.
The timeline gets pushed way back. Studies show delayed remodeling and delayed revascularization. Radiographically, BPTB allografts were found to have significantly less revascularization via MRI contrast enhancement compared to autografts at every time point up to 12-month post-surgery.
Which means?
This slow process means the allograft remains biologically vulnerable for a longer period, often requiring 18 months or more to fully equalize remodeling with an autograft. That extended fragility is why we must counsel for a more conservative, delayed return-to-sport protocol with allografts.
Contrast that soft tissue time frame with the efficiency of bone-to-bone healing, which is why BPTB is so fundamentally powerful in high-demand knees.
Bone-to-bone healing is the strongest form of biologic fixation we have, bar none. The process involves initial osteonecrosis of the implanted bone plug, but it's followed rapidly by revascularization, fibroblast invasion, collagen synthesis, and rapid incorporation by the surrounding host bone.
When is the critical period of mechanical weakness for a BPTB graft?
Based on histological studies, we know that at 3 weeks post-implantation, The weakest point remains the graft tunnel interface.
Okay.
But by 6 weeks, just a few weeks later, that interface has healed sufficiently that failure shifts away from the interface and into the patellar tendon insertion into the bone plug itself.
And that rapid shift allows for...
That rapid shift allows us to implement a more aggressive early rehabilitation protocol, which is a major benefit for professional or elite athletes.
Does the allograft bone plug behave similarly to the autograft?
It's similar, but with a critical caveat. While some studies show similar early incorporation, others suggest that allograft bone plugs require a longer incorporation time.
And there's a problem with the core of the plug, right?
Crucially, yes. Studies have shown that the central portions of the allograft plug may never fully incorporate, remaining a central necrotic void even at long-term follow-up. The healing primarily occurs peripherally, away from the influence of degradative enzymes found within the synovial fluid.
So you need perfect technique.
It emphasizes the need for pristine fixation and maximal tunnel fill when using allograft bone plugs.
Given these biological bottlenecks, particularly with soft tissue healing, what are the cutting-edge strategies being implemented or researched right now to accelerate integration?
Well, the primary mechanical strategy, and one we control in the OR, is maximizing the contact area between the graft and the tunnel. Studies show that simply creating a longer tunnel significantly increases the strength of the graft-tunnel interface.
More surface area for healing.
Exactly. Longer tunnel equals more friction and more healing surface area.
And biologically, we hear a lot about augmentation, adding something to the graft to speed things up.
Biologic augmentation is a very active area of research. Studies have shown superior healing outcomes in models when impregnating the graft with mesenchymal stem cells, or MSCs, which aid significantly in osseointegration.
What else is being looked at?
Similarly, the local application of bone morphogenic proteins, or BMPs, has been shown to increase bone formation around the graft. There is even research into inhibiting osteoclasts using agents like osteoprotegerin, which demonstrated greater bone formation in smaller tunnels in rabbit models.
So these are all attempts to just jumpstart the body's response.
They are all attempts to accelerate the body's innate response and bypass the slow pace of ligamentization.
Speaking of acceleration, there's a strong clinical pearl regarding pharmaceuticals that we should caution against because they can actually impair this primary healing response.
This is a critical caution for patient counseling. The primary healing response begins with the arrival of inflammatory cells, a process facilitated by cyclooxygenase 2, or COX2.
Which is what NS block.
Exactly. Studies suggest that standard nonsteroidal anti-inflammatory drugs and COX2 inhibitors may chemically interrupt this necessary early inflammatory phase. Therefore, our standard advice is to generally caution against the routine use of NSAIDs postoperatively, because they may impair the fundamental early healing response needed for integration.
Now we arrive at the segment that truly drives our clinical decision-making. The data regarding young, high-demand patients is absolutely overwhelming.
It is.
And it consistently suggests that allograft usage in this population is a risk not worth taking.
The consensus is firm and consistently reinforced across multiple large cohorts. Allografts carry a significantly increased failure rate in young, high-demand patients. This is the biological reality of slower remodeling colliding head-on with aggressive rehabilitation and high-stress return-to-sport demands.
Let's start with the hard numbers. The U.S. Military Academy cohort studying young cadets with a standardized, extremely high activity level all around age 19 offered a perfect controlled view of this problem.
Those results were a wake-up call for the community. In that cohort, cadets who received allograft reconstruction were found to be 7.7 times more likely to experience a graft failure compared to those who received BTTB autograft.
7.7 times.
And 6.7 times more likely to fail compared to all autografts combined. That margin is, as you said, clinically unacceptable for a patient with decades of high activity ahead of them.
That 7.7x difference isn't a statistical fluctuation, it's an undeniable biological failure. When you pool data across multiple systematic reviews focusing on this formulation, the risk gap remains wide.
It does. A meta-analysis of 7 studies focusing on patients younger than 25 or those with high Tegner activity scores, so military personnel, high school athletes, collegiate athletes, found a pooled failure rate of 25.0% for allograft.
1 in 4.
1 in 4, compared to only 9.6% for autograft. Furthermore, Barrett et al. Emphasized that allograft should simply not be used in young patients with high preoperative activity scores, citing a 2.6 to 4.2 times higher chance of failure in that high-demand group.
This forces the question. If the data mandates a strong autograft preference in this demographic, why is the overall usage rate of allograft still hovering at 30–40%? What gap exists between the evidence and common practice?
Often it comes down to perceived surgical complexity and patient desire to avoid donor site pain. If a surgeon isn't focused on objective long-term outcomes but rather short-term patient satisfaction, the allograft is an easy sell.
But we have to champion the data.
We have to.
To expand this beyond specific athletic cohorts, let's look at the large prospective registries which confirm these trends across broader populations. These registries, like Moon and Kaiser, give us real-world, general population data which carries significant weight.
The Multicenter Orthopedic Outcomes Network, or MOON cohort, demonstrated that allograft use was a powerful predictor of worse long-term functional outcomes. We measure these using scores like the IKDC and KOS.
And these are the standard patient-reported outcomes we use.
They are. And allograft recipients had poorer scores and carried an increased risk of subsequent surgery, showing an odds ratio of 2.33 for requiring an ipsilateral ACL revision.
And the Kaiser Permanente ACL Reconstruction Registry, that study really drilled down on the age variable, making the risk quantifiable.
That study is profoundly instructive. It confirmed that allograft use was associated with a 3.02 times increased risk of aseptic revision compared with BPTB autograft.
But the key finding was?
But the key clinically actionable finding was the age dependency. The risk of revision decreased by 7% for each year increase in patient age.
That's the smoking gun.
It is. It confirms that the failure mechanism is rooted in the mismatch between a slow-healing allograft and the activity level and demand profile of a young body. By the time a patient hits 35 or 40, their lifestyle demands often align better with the allograft's slower biological schedule.
So, synthesizing all this clinical data, what does our practical algorithm look like when we sit down with a patient and discuss tissue choice?
Our general guideline is rigid. Autografts are the default for patients younger than 35. These patients are presumed to be more active, have higher biological expectations for healing, and will place higher demands on the reconstruction.
And for autografts, how do we decide between BPTB and hamstring?
BPTB remains preferred for high-level athletes involved in cutting sports, football, soccer, basketball, where maximizing early stability and enabling aggressive rehabilitation is paramount.
Okay.
It's also favored for patients with a history of hamstring injury, or in very large patients where we can harvest a robust graft while minimizing the quad strength loss relative to body mass.
And hamstrings.
Hamstring autografts are generally preferred for most women due to better donor site cosmesis and for non-professional recreational athletes unless their activity level dictates the inherent bone-to-bone strength of a BPTB.
And finally, when do we confidently reach for the allograft?
Allografts are strictly reserved for older athletes, typically those over 35, whose lower activity expectations align better with the slower biological incorporation curve.
And in multi-ligament cases.
Yes, they are also frequently used in multi-ligament injury reconstructions, where we need large, predictable graft tissue while simultaneously conserving the patient's remaining native tendons.
With one huge caveat.
Crucially, when we do use allograft, we limit ourselves strictly to fresh, frozen, non-irradiated allografts, never the irradiated tissue.
The technical processing must pass the non-irradiated screen, otherwise you accept that unacceptable failure rate.
Precisely. We often prefer BPTB allograft over soft tissue options like tibialis anterior allograft in older patients due to the bone plug's known incorporation strength and fixation reliability.
Finally, let's briefly touch on the revision setting, where graft selection often becomes constrained due to previous harvests. Allograft use is understandably high here.
It is 49% reported in the Mars cohort.
That makes sense.
Yes, availability often drives choice in revision surgery, especially if the primary BPTB or hamstring has already been taken. However, even in the revision setting, the data still favors autograft.
Really? Even then?
The Mars study found that autograft use was predictive of improved outcomes, and patients were 2.78 times less likely to sustain a graft rupture compared to those who received allograft in the revision case.
So even in revision, autograft is better if you can get it.
We are seeing a high use of allograft due to necessity. We need tissue, and the patient's options are limited. But the biological reality is that a fresh autograft is still the superior choice, if available, often leading us to explore the contralateral side or the quad tendon.
Moving from the what to the how, let's switch gears and focus on the technical execution that maximizes the success of whichever graft type we choose.
Good idea.
Because we know that a poorly placed, anatomically incorrect autograft is still worse than a well-placed allograft.
Technique is paramount. This is where the surgeon becomes the deciding factor, regardless of the tissue bank's efforts. Success starts well before the patient enters the OR.
Rehab.
We begin with a thorough history and physical exam, weight-bearing films, and MRI to assess concomitant injuries, meniscus, collateral ligaments, and critical posterolateral corner structures.
The preoperative rehabilitation phase is non-negotiable, often lasting 3-6 weeks. But many young athletes try to skip it because their knee feels fine.
It is the most critical preparatory phase. The goal of preoperative rehab is achieving full active range of motion, symmetric quadriceps strength, and a normal heel-to-toe gait.
You never operate on a stiff knee.
You don't want to go in with a stiff, angry knee that is locked into extension loss because post-op stiffness, or arthrofibrosis, is a nightmare. Furthermore, managing concomitant injuries requires staging.
Like what?
For an acute posterior lateral corner injury, we repair that complex first and delay the ACL reconstruction 4 to 6 weeks. For an associated high-grade MCL injury, we often delay the ACL surgery for 4 to 6 weeks to allow the MCL to heal first.
The fundamental shift over the last decade has been firmly toward anatomic ACL reconstruction, regardless of the graft type, moving away from older, non-anatomic techniques.
Anatomic placement is the consensus, and achieving anatomic femoral tunnel placement is best done through a medial portal approach for the femoral tunnel.
Not transtibial.
No. This is a technical preference that allows us to place the femoral tunnel independently of the confines of the tibial tunnel, unlike the older transtibial technique that forced the femoral tunnel into a non-anatomic vertical position.
What are the advantages of the medial portal approach, beyond just better positioning?
Geometrically, it's superior. The medial portal approach has been shown to decrease the incidence of tunnel widening and minimize the divergence angle of the interference screw. It just gives us better geometric control.
Right.
Especially when aiming for that small, low starting point. Furthermore, during notch preparation, we emphasize maximal preservation of the tibial stump.
You leave the remnant.
Leaving the torn ACL remnant behind, where possible, enhances both proprioceptive, the knee's sense of where it is in space, and vascular properties of the reconstructed knee. We also rarely perform a notchplasty unless strictly necessary, and we always leave the fat pad intact to prevent scarring and patella baja.
Let's nail down the geometry for our listeners. Starting with the femoral tunnel, what are the key spatial requirements?
We aim for the center of the femoral footprint, which is typically 4 to 6 millimeter anterior to the posterior wall of the notch, usually at the 10 o'clock or 2 o'clock position, depending on the side.
And the knee position for drilling is key.
Crucially, when we drill, the knee must be flexed deeply, typically to 120 degrees. This deep flexion is the critical surgical safeguard.
Why 120 degrees? What's the consequence of drilling in lesser flexion?
That deep flexion is critical for 3 reasons. First, it improves visualization. Second, it maximizes the length of the femoral tunnel, which aids in fixation strength. And third, it prevents catastrophic posterior cortex breach.
You don't blow out the back wall.
Exactly. If you breach the posterior cortex, you risk neurovascular injury and immediate graft failure because there's nothing to hold the graft in place.
That's the core safety principle. Now, the tibial tunnel.
Tibial tunnel placement is achieved anatomically using an elbow guide. We use fluoroscopy X-ray guidance to confirm the final position before reaming. On the lateral view, with the knee in extension, the pin should enter the tibial plateau at the junction of the anterior and middle thirds and be in line with, or slightly posterior to, the radiographic shadow known as Blumensatt line.
I recall the importance of undersizing the tunnel initially.
Yes. The tibial tunnel is intentionally created using a reamer that is 0.5 to 1.0 millimeters smaller than the measured graft size. We then use dilators to sequentially expand the tunnel to the final size.
And this does what?
This process compacts the cancellous bone, which theoretically enhances initial tunnel integrity and decreases post-operative tunnel widening before the graft is seated. It's like pre-compressing the soil before pouring the foundation.
Once the tunnels are prepared, we move to fixation. Your preferred method involves an endo button on the femoral side and post-fixation on the tibial side.
That's right. For the femoral side, the endo button provides excellent cortical fixation, suspending the graft and maximizing the length of the graft housed within the tunnel. For passage, the knee is flexed to 90 degrees.
And orientation matters for BPTB.
If we are using a BPTD allograft, we ensure the cancellous portion of the bone plug is oriented anteriorly. This allows the denser cortical portion to reside posteriorly in the tunnel, which may enhance initial healing and stability.
And the final fixation at the tibial end? What's the critical detail about knee positioning there?
We prefer tibial post-fixation. This involves securing the tibial lid sutures individually around a 4.5 millimeter large fragment cortex screw with a washer, which acts as the post. The critical detail here is the knee position. The sutures are tied with the knee positioned in 15 to 30 degrees of flexion.
And that does what exactly?
This provides the optimal resting tension for the graft before the screw is fully seated, ensuring we avoid over-tensioning, which could cause mechanical failure or joint compression, but also ensuring the knee isn't lax.
Lay out the post-op roadmap, highlighting the key difference based on graft choice, particularly the time difference for allografts.
In the initial phase, week 1, the patient is weight-bearing with crutches, and the brace is locked in full extension to protect the graft from anterior shear forces.
And exercises start immediately.
We focus immediately on basic home exercises, quadricep sets, straight leg raises, and heel slides, aiming for full extension immediately.
When does the restriction start to lift?
The brace is typically discontinued around 1 month, once the patient achieves full range of motion and a normal heel-to-toe gait. The focus then shifts to strengthening using closed-chain, low-resistance exercises, think exercise bicycles or leg presses.
And a key warning here.
A crucial cautionary note. We strictly avoid open-chain knee extensions for several months, as they place excessive anterior shear stress on the newly forming graft, which is still biologically vulnerable.
And the return to sport, that's where the biological trade-off becomes tangible, right?
Absolutely. Return to sport is gradually permitted between 6 and 12 months, based entirely on strength, functional testing, and patient symptoms. However, we explicitly counsel patients who receive allografts that they must allow a longer time for full biological incorporation.
So you push them back.
Given the documented delayed remodeling, we push allograft patients closer to the 9 to 12 month mark, or even longer, ensuring they meet strength benchmarks before clearance.
This has been an incredibly detailed audit of the literature and technique. At the end of the day, it seems the conflict boils down to one fundamental trade-off that the patient must internalize. The elimination of acute surgical pain and donor site morbidity that the allograft offers versus the biological guarantee of rapid incorporation and superior long-term mechanical stability provided by the autograft.
That is the core conflict. And the current evidence base compels us to individualize patient counseling based almost entirely on age and activity level. For the patient over 35 with lower activity demands, the non-irradiated allograft is a reasonable, well-tolerated choice.
Their biology matches their lifestyle.
The biological schedule matches their lifestyle.
But for the young, elite, or even just highly active individual under 25, the data is unforgiving. We saw the U.S. Military Academy data demonstrating that allograft recipients were up to 7.7 times more likely to fail.
It's a huge number.
We've done an exceptional job minimizing the risk of disease transmission and refining our surgical techniques to be anatomic.
Despite all of our technical advances, the biological imperative of slow allograft remodeling remains the fundamental bottleneck.
So here is the provocative thought we must leave the listener with. For that young demand patient, is any surgical convenience, reduced operative time, or even reduction in early donor site pain worth accepting a graft risk profile that is documented to be 7 times higher?
This forces us to ask, are we doing enough preoperative screening and optimization to try and mitigate the allograft's biological shortcomings in our most demanding patients? Or should we simply accept the evidence that for the young, high-demand athlete, the autograft, with its inherent biological superiority, is the only ethically and scientifically defensible answer?